Hello, thank you for having me. I'm happy to present to you the research project Diagnostic Accuracy of a Shockable Rhythm to Identify Patients with a Short No-Flow Time. I do not have any conflict of interest to disclose. The whole research program has been funded locally, both from the university and my local hospital. I'm obligated to say that this project was prepared using the ROC Cardiac Epistry 1-2 entry from the NHLBI Biologic Specimen and Data Repository Information Coordinating Center, and that it does not necessarily reflect the opinions or the views of the ROC Cardiac Epistry 1-2 entry or the NHLBI. Now, let's discuss the heart of the matter. Out-of-hospital cardiac arrest is an important emergency medicine topic with around 400,000 cases per year in North America only. Despite an overall improvement in care for these patients, only 10% of them will survive to hospital discharge. Extracorporeal resuscitation, or ECPR, has been proposed as a tool to improve the outcomes of selected out-of-hospital cardiac arrest patients. The initial electrical rhythm is the most often used ECPR selection criteria. In addition, patients are usually considered only if they have a short no-flow time, and that measure is necessarily uncertain for patients with an unwitnessed out-of-hospital cardiac arrest. It has previously been proposed that patients with an initial shockable rhythm could be assumed to have a short no-flow time, and therefore be considered for ECPR even if they have an unwitnessed arrest. However, the evidence supporting this remains conflictual. To resolve that issue, we aim to determine the sensitivity, specificity, and likelihood ratios of an initial shockable rhythm to identify patients with a short no-flow time, 5 minutes or less. To do this, we used a large North American cohort of out-of-hospital cardiac arrest from the ROC Registry 1-2 entry. From that cohort, we excluded patients who were less than 18 years old, who met obviously dead criteria, who were not treated by EMS, who received bystander CPR or had an unwitnessed arrest, or who had missing data which precluded us from performing our main analysis. We considered the time from dispatch call to the first EMS electrical rhythm assessment to be the no-flow time, including only patients with a witnessed arrest without bystander CPR allowed us to therefore describe the natural evolution of the presenting rhythm. Using that data, we calculated the sensitivity, specificity, positive likelihood ratio, and negative likelihood ratio of an initial shockable rhythm to identify patients with a no-flow time of 5 minutes or less. We also performed supplemental analysis with no-flow times of 2.5 minutes or less, 7.5 minutes or less, or 10 minutes or less, and a final set of sensitivity analysis with the inclusion of patients with an EMS witnessed out-of-hospital cardiac arrest. Over 200,000 patients were included in the initial registry. From these, we included 31,773 patients in the present study. More than 8,000 of them had an initial shockable rhythm, and 23,000 of them had an initial non-shockable rhythm. The vast majority of these patients were male, with a mean age of around 65 years old. For our main results, we showed that the presence of an initial shockable rhythm had a sensitivity of 45% and a specificity of 70% to identify patients with a no-flow time of 5 minutes or less. This resulted in a positive likelihood ratio of 1.49 and a negative likelihood ratio of 0.79. We also showed that the sensitivity lowered as we tried to identify patients with longer no-flow time. The specificity was a bit less affected by this. The positive likelihood ratios also remained relatively stable throughout the different delays. These findings were different when we included patients who experienced an EMS witnessed cardiac arrest, as the rate of initial pulsus electrical activity was very high amongst these patients. the sensitivity actually improved when we increased the no-flow time delays in these analyses. This resulted in very poor positive likelihood ratios amongst these patients. To conclude, the presence of an initial shockable rhythm has a poor sensitivity but an average specificity to identify patients with a short no-flow time. Patients with an EMS witnessed cardiac arrest have a much higher frequency of initial PEA than other out-of-hospital cardiac arrest patients, and therefore constitute a different population as they present very differently. I'd like to thank all of the co-authors and welcome your questions.
Hello, my name is John Cameron. I'll be presenting the study titled Novel Pencil Hold Seldinger Technique for Central Venous Catheterization. It should be noted that the study authors were unavailable to present this information. As chief resident of this class and someone who is interested in academics, I have volunteered to present this information with the author's consent. Authors as seen here. We have no financial or non-financial disclosures. By way of introduction, prior literature has suggested that decreasing the number of attempts to successful catheterization decreases the CVC complication rates. Ultrasound guidance and sterile technique notwithstanding, prior research yields little evidence for lowering the mechanical or immediate complications. Examples of immediate or mechanical complications would be multiple arterial venous sticks, arrhythmias, embolizations, pneumothorax, or nerve or tracheal injuries. The pencil hold technique was inspired by a surgeon's grasp of surgical blades in the operating room. In theory, this pencil hold technique offers more surface area for contact between the operator's hand and the introducer needle and syringe. We explored the differences in unsuccessful catheterization rates and time to successful catheterization between traditional plunger hold and the steady hold intravascular pencil hold technique. Our objectives are to examine the utility of an alternative pencil hold adjunct for CVC placement in high fidelity gelatin mannequins. Our methods: study design was a true experimental quantitative pilot study. This was completed at the Clinical Simulation Center for Education at Christus Spawn Shoreline, and we had 30 ED residents at an academic medical center, PGY 1 through 3. Participants were pre-briefed on the Simulation Center rules and responsibilities. They completed a structured survey of prior CVC experience and received a video in-service session reviewing the two techniques. The lead study investigator performed time measurements and assessed satisfactory cannulation. Time to catheterization was defined as puncture of the trainer skin surface to successful catheterization confirmed by fluid return into the syringe or by visualization within lumen by ultrasound. Our statistical methods: we used a Wilcoxon signed rank test to compare the mean cannulation times between the techniques. Let's review our results. We had 30 total subjects enrolled, 11 being interns, 10 PGY2, and 9 being PGY3. 29 of 30 had successful cannulation with the traditional holds, 28 of 30 with pencil hold techniques, and all 30 participants had successful cannulation on second attempts with both techniques. Overall, the mean to cannulation times were similar between the techniques, with traditional being 5.5 seconds and pencil hold being 4.7 seconds. This was not statistically significant on the first attempt cannulation time. Statistically longer time to cannulation for the traditional hold technique during the second attempt was seen, with the traditional hold being 5.8 and the pencil being 4.8 seconds. That is repeated here, seeing that there is a statistical significant difference between the two on repeat attempt. So by way of discussion, our CVC complications deemed avoidable via CMS as hospital-acquired conditions. Failed catheterization attempt is strongest predictor of the CVC complications. Risk factors for these complications include prior attempts at the placement and more than 2 needle sticks. Despite our hypothesis that the pencil hold technique would result in fewer access complications, There is no significant difference between the techniques seen after data collection. The standard of care for CVC placement is the traditional hold utilizing the Seldinger technique. Therefore, our study participants have used that standard technique extensively in clinical practice with very limited practice with the pencil hold technique. When we saw the second attempt with the pencil hold, the operators showed a statistically significant shorter time to the successful cannulation. This higher successful cannulation on second attempt suggests a reduction in unsuccessful attempts with more practice. Shorter mean time to successful cannulation a second attempt suggests an improvement in control and or less inadvertent movement of the needle tip with successive attempts and experience. A few limitations. Our study did not control for each participant's prior experience and the comfort level with the traditional handhold technique among the trainee levels. Furthermore, our sample size is limited to a relatively small size secondary to availability of resident trainees. Larger sample sizes may reflect a different, more clear outcome. In the future, larger studies will be needed. Participants with comparable prior experience with both techniques may be able to more clearly delineate a difference between them. In conclusion, our results provide preliminary evidence regarding the potential for the pencil hold technique to offer a safe alternative. Larger studies are warranted to further compare these techniques. Here are my references. Thank you.
Hello, my name is Dr. Sakina Sojar, and I'm a Pediatric Emergency Medicine Fellow Physician at Hasbro Children's Hospital and Brown University. Today, I'm delighted to share with you our research and abstract entitled, Use of a Pedal-Operated Compressor is Non-Inferior to the Use of a Standard Hand-Compressed Bag Valve Mask. The standard bag valve mask, utilized universally among hospitals, requires that a single provider affix the mask to the face using an E+C clamp technique with one hand while compressing a self-inflating bag with the second hand. This maneuver requires pushing on the face with the index finger and thumb while lifting the jaw into the mask with the middle, ring, and pinky fingers. This operation proves difficult for many clinicians, especially those with smaller hands. Several studies have demonstrated that creating a two-handed seal is superior to the single-handed seal, allowing for more reliable breath delivery during resuscitation with minimal fatigue. Our study aimed to assess the efficacy of a novel single-provider bag valve mask device that utilizes a foot pedal as a bag compressor, allowing both hands to be available to create a seal on the face. The addition of a foot pedal introduces a third limb, allowing for a single provider to utilize a two-handed seal. This was a randomized, single-blind, crossover study. It took place in our institution's simulation center. Providers from both emergency medicine and outside of emergency medicine were invited to participate in the study. Participants were asked to fill out an initial survey describing their gender, profession, number of patients they had previous bag valve mask ventilation experience with, hand dominance, hand size, and shoe size. After undergoing a teaching session to learn how to use both the standard device and the novel device, each participant was then randomized to give metronome-guided breaths to a high-fidelity 70-kilogram simulation mannequin with one of the two devices. After a 2-minute rest period, they were asked to repeat the exercise with the other device. Data on the delivered tidal volume was collected with simulation software. Analysis examining differences in mean tidal volume delivered for sensed breaths for the standard device versus the pedal device was conducted using a paired sample t-test. A secondary analysis was conducted to compare differences by prior bag valve mask ventilation experience. Participants were asked to rate ease of use of both devices using a 5-point Likert scale, in addition to providing subjective, open-ended feedback on using the novel device. So what did our study population look like? We had 26 non-EM providers, 28 EM providers, and 3 EMS providers participate in our study. 64% were female, and the majority were right-hand dominant. About half had experience with bag valve mask ventilation in greater than 30 real-life clinical scenarios. 36% of participants had experience in less than 10 real-life scenarios. So how did the pedal device compare to the standard device? The mean tidal volume delivered by the pedal device was 446.1 mLs. compared to 341.7 mLs by the standard bag valve mask device. The mean delta was 101.4 mLs. It should be noted that the simulation software considers an appropriate breath to be between 400 mLs and 700 mLs. Thus, the mean volume was in range for the pedal device, but out of range for the standard device. Furthermore, there was no significant difference in change in delivered tidal volume in the standard bag versus the pedal device for those most experienced in prior bag valve mask ventilation compared to those with least experience. When comparing ease of use, 81% of participants described using the pedal device as easy or very easy versus 41% for the standard bag valve mask. 66% reported preference to use the pedal device in a real-life clinical scenario. Here's a sampling of some other things that participants had to say.
Use of a two-handed seal felt more secure and less tiring.
I have small hands, so being able to use the two-handed grip made things feel more comfortable and effective.
May need to be height adjusted for shorter versus taller people.
I'm a natural toe walker, so pushing with the tip of my toe instead of my heels seems a lot more practical.
I had so much more time to readjust. With the standard, I was so busy pushing while giving breaths, I felt like it wasn't effective.
We concluded that utilization of a novel foot pedal operated bag valve mask may allow a single provider, regardless of prior experience with BVM ventilation, to deliver greater and consistent appropriate tidal volumes with more ease compared to the standard bag valve mask during manual respiratory resuscitation. Our references will be available on the last slide, and I thank you for your attention, and we're looking forward to hearing your comments and questions regarding our project. Thank you again.
Hello, and thank you for the opportunity to present this topic. My name is Ari, and I'm an emergency physician at UMass Medical Center in Worcester, Massachusetts, and this presentation is entitled Cardiac Anatomy Visualized by Parasternal Long and Subxiphoid Axes, which explores ultrasound use during cardiac arrest and ACLS resuscitation. This study is a continuation of the prior Reason trial from 2016. The portion of our study that I am presenting today sought to determine which approach, subxiphoid or parasternal, would be more efficient as a viewing window to use when doing a cardiac ultrasound during a pause in CPR. We looked at which anatomic structures were able to be visualized with each approach within a time frame that would ideally not interfere with the ACLS algorithm. Our hypothesis was that subxiphoid would be a better viewing window to visualize cardiac anatomy as compared to parasternal long. Our study was a prospective multi-center randomized interventional trial involving 29 sites. The primary outcome of this study was the time to image acquisition versus overall image quality based on approach, with each ultrasound clip being graded on a quality scale to essentially see how much time was needed to acquire an acceptable ultrasound image. This presentation focuses on our secondary outcome, which looked at the consistency with which specific anatomical structures were able to be visualized based on each viewing window. The subjects were patients in the emergency department that were not in cardiac arrest at the time the clip was taken. Each site enrolled at least 10 physicians who each scanned 10 unique individual patients, acquiring one subxiphoid and one parasternal long clip per patient. The time to acquire an image was recorded, and the images were subsequently reviewed and anatomic landmarks visualized. This study was done with IRB approval and patient consent obtained prior to each enrollment. In total, over 6,000 images were obtained by 311 different clinicians who scanned 3,124 patients over a 7-month period. A small amount of cases were excluded due to issues with data transfer, and in total, 6,097 clips were analyzed for the secondary outcome. This slide breaks down how consistently all of the various anatomic structures that could have been visualized by each approach were actually seen. The two main structures that were looked at were the pericardium and the maximum amount of chambers that were able to be visualized by each approach. Comparing the two approaches, 79% of the parasternal long clips were able to visualize the pericardium, and 69% were able to see all three chambers that could be seen with this view. Comparatively, the pericardium was visualized in 65% of subxiphoid clips, as opposed to 52% of clips showing all possible chambers that could be seen with the subxiphoid view. This table breaks down the visualization of various anatomic structures by the amount of time it took for the image to be acquired, with the times for the subxiphoid view seen on this slide. As we can see, looking at each 5-second interval, the largest proportion of image clips were taken within the 10-second ACLS window. Of the 3,036 subxiphoid images, 1,639, or about 54%, were able to be done in less than 10 seconds, with the individual percentages of each structure visualized laid out on the table here for comparison. This table shows the same data, but for the parasternal long view. Similar to the subxiphoid view, the majority of clips were able to be obtained within 5 to 15 seconds, with the largest proportion again being in the 5 to 10 second range. As the table shows, a large proportion of these images were able to visualize the important anatomic structures of the pericardium and all possible viewable chambers. Comparing the two views, we saw that the parasternal long view was more consistently able to visualize the pericardial space and multiple chambers as compared to the subxiphoid view. To be fair, there are structures that can only be viewed in parasternal that subxiphoid cannot see, such as the aortic root, and subsequently certain structures that can only be seen in subxiphoid that cannot be seen in parasternal, such as a side-by-side comparison of the ventricles or the right atrium. While it appears that the subxiphoid view has a greater potential to visualize more structures overall, based on the data, it appears that the parasternal view was more consistently able to visualize the pericardium and the left ventricle, which I felt were the two main structures that are most important to ACLS for a patient in cardiac arrest. The immediate things we want to know when doing an ACLS ultrasound is to see if there's cardiac activity, which requires visualization of the heart chambers, primarily the left ventricle, and also the pericardium to see if there's an effusion that requires an emergent pericardiocentesis. The limitations of this study is that it was performed on patients who were not in cardiac arrest and did not have either a person or a Lucas machine in the way performing CPR as the images were being taken. Despite this, I think our study can help shed light on the optimal ways to incorporate ultrasound into the ACLS algorithm and support our overall goal of using ultrasound during cardiac arrest and show that it can be done within the prescribed time frame for CPR and will not detract from proper resuscitation. I want to extend a thank you to my colleagues, mentors, and co-authors and everyone involved for their time and effort in helping this study come to fruition.
Thank you very much for having me today. My name is David Sheridan, and I am an assistant professor of pediatric emergency medicine at Oregon Health Science University. The title of our study was Point of Care Capillary Refill Technology Improves Accuracy of Peripheral Perfusion Assessment. I do have one pertinent disclosure. I was part of a technology that developed, and I'm a co-founder in a startup company called ProMedics, which is developing the technology that was being studied today. This relationship is reviewed by two different committees at Oregon Health Science University and on file. Sepsis is currently the leading cause of U.S. hospital deaths and readmission rates. Sepsis currently affects 1.7 million patients in the United States, and every hour delay in diagnosis increases mortality by approximately 8%. The Andromeda Shock trial showed favorable results when resuscitation for sepsis is guided by capillary refill rather than blood lactate levels. They also found decreases in morbidity and mortality in this study. The ability to measure dynamic changes in peripheral perfusion, we think, can individualize sepsis resuscitation to prevent both under and over resuscitation. However, capillary refill has been limited due to its subjectivity to date. Technology that can rapidly assess capillary refill changes at the bedside and used in triage potentially for earlier detection could improve this. Through a problem-based innovation approach, we identified the need for technology to rapidly measure capillary refill in emergency department patients being evaluated for sepsis to allow for both early detection and potentially guide resuscitation. Our group created a non-invasive finger sensor using a light reflectance detector and pressure. You can see here the picture on the left is the wrist housing, which holds the Bluetooth and the various algorithms that detect the capillary refill changes. And then the finger sensor sits on the finger that just allows pressure application and then detection of the capillary refill time. The gold standard really in clinical trials in the literature has focused on using rigorous trained research assistants who use very protocolized processes and use chronometers to determine capillary refill time, as there's no other gold standard to date. This study, therefore, aimed to assess the correlation of the device to research assistant capillary refill time, as well as comparing that to provider capillary refill time. This was a prospective, convenient sample of adults in both the ED and the ICU. Research personnel obtained capillary refill time in two different ways. They had a manual protocol where they applied pressure to the nail bed for 3 seconds, releasing and then using a chronometer to determine the time for capillary refill. In addition, they did a very similar thing with a capillary refill device. Obviously, there's no chronometer. They had the device on the finger, applied pressure for 3 seconds, let go, and the device did the calculations on the exact same patient. Importantly, they always did the manual assessment before the CRT device so that they were not able to bias their measurements. In addition, treating physicians were asked to obtain manual capillary refill time on the same patients in the emergency department, although they were unrelated to the study. The results, Pearson correlation coefficients, were performed for each group of measurements. The ED cohort consisted of 29 patients with an average age just over 46 years and almost 41% male. The ICU consisted of 25 patients with an average age of 58.5 years and 40% male. The ICU patients underwent sequential CRT measurements over their admission, so therefore resulting in 69 measurements for comparison, whereas the ED had 29 single measurements to compare. In terms of the provider CRT assessment compared to the gold standard research assistant assessment, there was a weak association with a Pearson correlation of 0.3, as you can see on the graph here. This graph is a depiction of the capillary refill time device compared to the gold standard research assistant assessment of CRT, and we found a good association with a Pearson correlation coefficient of 0.7. There are limitations to this study. This is a very small, convenient sample that did not have any specific underlying diseases or outcomes. However, it was really aimed to evaluate the association of the new technology to what is really kind of considered gold standard assessment of capillary refill time. That gold standard we defined as research assistants who are rigorously trained in determining capillary refill time using a chronometer, the same amount of pressure, the same time of pressure to the nail bed. This is really what's been used in prior studies and clinical trials and resulted in the clinical trial findings that we've had. So that's why we use that as gold standard. And then I think the third limitation is this is technology that our group is currently developing. However, the study data was collected by non-conflicted research assistants, and so the group that was developing the technology was actually not involved in enrolling of the patients. In conclusion, capillary refill time is an important marker of end organ perfusion that can be performed rapidly at the bedside. However, wide subjectivity has limited its use to date. This simple, non-invasive technology has the potential to allow providers of any training to obtain accurate data. This technology may have the potential to help recognize ill patients in a more time-efficient manner in the emergency department. However, larger studies are definitely needed. With that, I'm happy to take any questions, and there is a beautiful view of Portland, Oregon tram and Mount Hood in the background. Thanks a lot.
Hello, my name is Josh Davis. I'm an emergency medicine physician in Wichita, Kansas. I'm going to be speaking to you today about my research on the mortality of critical care interventions in COVID-19, a systematic review. Thanks for joining us at SAEM21 virtual. I have no disclosures regarding this work. By way of introduction, we all know how COVID-19 has affected our lives and, more importantly, our work in the emergency department. We've seen several waves of illnesses, and there may be another one looming in the near future. It's not uncommon, regardless of COVID-19 in the emergency department, for us to see maximally aggressive care in patients we know are likely to have a poor outcome. And knowing the mortality of many of these interventions may be able to allow us to have more informed and educated discussions with family regarding goals of care and what is in the best interest of a patient. So therefore, the goal of this project was to evaluate the mortality of critical care interventions in COVID-19 using a systematic review and possibly meta-analysis. Our methods: we attempted to follow the PRISMA guidelines, which some of you may be familiar with, are a best practice in systematic review reporting. Includes using multiple databases, a search protocol, and multiple reviewers of articles. We did eventually find that the data was too heterogeneous to perform a formal meta-analysis. The databases we used included PubMed and a specific CDC collection of articles that is a subset of multiple databases, including PubMed as well, and several preprint databases, including medRxiv, as I used to call it. Have since learned that it's supposed to be medRxiv. That's a Greek chi letter that you see in many of the preprints that have come out recently. We searched the data from November 2019 to April 10th, 2020. That's an important thing to recognize, is that we stopped early on in the pandemic, and so data may have changed. We looked at 5 outcomes. So intensive care unit admission, endotracheal intubation, hemodialysis or renal replacement therapy, ECMO or extracorporeal membrane oxygenation, and CPR or cardiopulmonary resuscitation. Our results. You'll see here that through our database searches, we identified 6,975 articles. 20 of them ended up included in our analysis after we went through the PRISMA process to identify articles and the best practice in systematic reviews. You'll see a summary of our results listed here. So for ICU admission, we identified 17 studies on 9,800 patients, and the mortality was 32.5% across all of the studies. For endotracheal intubation, we had 13 studies of 3,865 patients, and the mortality was significantly higher at 64%. And then for hemodialysis, you'll see we found 5 studies of 1,203 patients, and the mortality was 75.3%. For ECMO, we only identified 2 studies that met our inclusion criteria of having greater than 5 patients. One of these studies had a mortality of 50%, and that study included 8 patients on ECMO. And then another study included 6 patients on ECMO and had a mortality of 83%. Several other studies reported smaller numbers of somewhere between 1 and 5 patients on ECMO and varying levels of mortality. And then we only identified 1 study on CPR, but I find this to be a really informative study. This was on 136 patients, and of the 136 patients who had CPR, 4 of them were alive at 30 days, so that's 2.9% or about 3%, and 1 had a good neurologic outcome, or 0.7%. That's a cerebral performance category of 1 or 2 is what the authors defined that as. So some of the limitations that are important to recognize: ICNARC, which is the Intensive Care National Audit Research Center, is a UK database that provided more than 50% or nearly 50% of the patients in most of our analysis. So there may be a bias towards UK patients and the limitations of that database in and of itself. In addition, the time of our search was only through April 2020. And so it's important to note that our knowledge of COVID-19 and our ability to initiate life-saving interventions and the mortality of COVID-19 overall has decreased a fair amount since that time frame. That was very early on in the pandemic, and a lot of the data from these studies that we included are outside of the United States and before we had a lot of knowledge of interventions. For example, dexamethasone being one of the interventions that has since been shown to reduce mortality. The other thing is, as I mentioned before, we did not perform a formal meta-analysis. The numbers that are here and reported are numerator and denominator. There's no weighting, there's no controlling for confounders. The data was definitely too heterogeneous to perform a meta-analysis and get accurate results out of that. And then individualization. So it's important to recognize that we did not control for individual variables of patients like age or comorbidities. And that's an important thing to recognize when we're doing a study like this. So by way of discussion, I think some people have talked about a universal DNR, and this data may help inform that discussion. There is a 4th wave that maybe has been developing, and that also maybe make this data more relevant. And then it's important to notice the rapid changes that have occurred with COVID-19 data, and that this mortality data may be slightly outdated, and to bring that into consideration. So the conclusion is hopefully that you can use this data to inform future discussions on COVID-19 and mortality in your patients. And if there's any questions, comments, concerns, opinions, anecdotes, monologues, diatribes, or riddles, you can send them my way at jjdavis@vitality.com. Thank you for joining.
Hi, my name is Nick Mazer. I'm a current third-year medical student at Marion University College of Osteopathic Medicine in Indianapolis, Indiana. To start, I'd like to thank the Society for Academic Emergency Medicine for the opportunity to present at today's conference. I also want to thank those listed on the screen as co-authors, especially Dr. James Paxton, who's affiliated with Wayne State University School of Medicine in Detroit, Michigan. Our project was titled, Does Lactate Clearance Predict Mortality in Pre-Shock Sepsis Patients? I don't have any disclosures. So to introduce our study, we saw that surviving sepsis guidelines recommended aggressive resuscitation for septic patients within their first 3 hours of ED arrival, and for those with an initial lactate above 4 millimole per liter, among other things. However, we saw that there was little guidance provided for those patients which we determined as pre-shock, with a lactate between 2 and 4 millimole per liter. We also saw that lactate clearance is often used to evaluate the adequacy of resuscitation in septic patients, and the relationship between these lactate clearance and mortality among pre-shock patients is not well understood. This project is a part of a larger study we're participating in order to help ED physicians evaluate markers for resuscitation in these pre-shock patients. For our methods, we performed a retrospective review of ED visits for sepsis by adult patients at 2 urban institutions from January 2010 to March 2015. Patients were included if they were diagnosed with sepsis in the emergency department and had an initial lactate level, which again we determined as pre-shock, of between 2 and 4 millimole per liter. These initial lactate blood draws were performed within 3 hours of ED presentation, and all patients received a second lactate draw within the first 24 hours. Percent changes between first and second lactate draw were then stratified by percentiles, including increase from first to second, and then decrease from 0 to 10, 10 to 20, 20 to 30, 30 to 40, and over 40%. We collected data including patient demographics, vital signs, laboratory tests, medications given, length of ED and hospital stay, and need for mechanical ventilation. Descriptive data analysis and group-wise comparisons were performed, including logistic regression. For our results, we had a total of 69 patients with a mean age of 65.6 and a standard deviation of 17.87. 58% of our population was male and 72.5% was African American. Continuing on our results, our overall mortality rate was 31%, so 22 out of 69. And those who died had a higher mean second lactate, 3.65 versus 2.52. And this was statistically significant. Most patients who survived had a decreased repeat lactate level. Going further into our results and taking a look at mortality among lactate clearance with these stratified percentiles, we didn't find any statistical significance, but wanted to show this graph as well as the numbers over here on the right. So as you can see, 21 patients out of 69 had an increase from initial lactate to second lactate. 6 had a 0 to 10% decrease. 3 had a 10 to 20% decrease. 9 had a 20 to 30% decrease. 8 had a 30 to 40% decrease. And 22 had a 40% or larger decrease. Again, it was 69 patients total. On the left, you can see that the maroon bars are those who expired versus the blue bars are those who survived. So in conclusion, we saw that pre-shock patients with a higher second lactate level appear to be less likely to survive hospital discharge. And we found no statistical difference in mortality rates with increasing lactate levels or with lactate clearance stratified by percentiles. And we feel that further study is needed, specifically with larger data sets. Only having 69 patients we feel is a limitation, as well as only having 2 urban institutions limits the generalizability of the study. Thank you again for listening to my presentation today here at SAEM21. And thank you for your interest in this study. If you have any questions, please contact me, Nick Mazer, with any questions, and my email is listed on the screen below. Thank you.
Good afternoon. My name is Sean Van Heer. I'm a third-year medical student from Queen's University in Kingston, Ontario, and this is my research project. As many of you know, patient resuscitation can be cognitively overwhelming. This is especially true for junior residents who not yet have the mental schemas or experience to handle the complexity and acuity of resuscitations. Medical simulation straddles the line between the classroom and clinic, giving us the chance to observe residents' resuscitation skills while studying factors like stress and cognitive load. Simply put, cognitive load is the amount of mental effort required to perform a task. Correspondingly, performance declines when cognitive load outweighs cognitive resources, which is known as a state of cognitive overload. Cognitive load experts suggest that clinically, cognitive load is comprised of 2 components: intrinsic load, which encompasses task-related stress and complexity, and extraneous load, which is anything that uses mental effort not related to the task at hand. Stress is innate to emotionally charged environments like resuscitation, simulation, and OSCE assessments, and stress has been shown to contribute to cognitive load. So I want to know, how can we better prepare residents to handle the cognitive and emotional burden of resuscitation? Thankfully, the military, athletes, and yogis everywhere have demonstrated the use of breathing techniques to modulate emotion. Box breathing uses slow, deep respirations to leverage higher-level thought processes and innate physiology to mitigate the sequelae of the human stress response. Specifically, box breathing has been shown to physiologically decrease heart rate and psychologically decrease anxiety and hyperarousal, which begs my research question. What effect does box breathing have on the intrinsic and extraneous cognitive load of residents, and can using this breathing technique protect junior residents from cognitive overload and performance decline? So here are our study objectives. First, we want to investigate the effect of box breathing on intrinsic and extraneous cognitive load. And second, we want to explore the interplay between stress, cognitive load, and performance. We had 39 PGY1, so first-year residents from 14 specialties, participate in a simulation resuscitation OSCE as part of their first-year training course. Their performance is graded by faculty based on entrustment levels, and after each station, we added in that they completed a cognitive load questionnaire and the STI-6 stress questionnaire. Our intervention was that before each OSCE station, half of the residents performed 20 seconds of box breathing, while the other half performed a basic color naming task, where they were just showed different colored squares, and they were asked to identify what color they were out loud. So here's the overall flow. First, residents performed either box breathing or the color naming control task, and then they completed the simulated resuscitation, where they were assessed by a staff physician. They then completed the cognitive load questionnaire and the stress questionnaire before repeating this for 4 different clinical steps. Now for the results. Our goal was to explore the effect of box breathing on the components of cognitive load. So here's the intrinsic and extraneous load of the box breathing and control groups. Now remember, intrinsic load is a task-related stress and complexity, while extraneous load is encompassing off-task distractions. What we found is that box breathing significantly lowered the intrinsic load of residents. However, there is no difference in the extraneous load. So to further investigate the clinical implications of box breathing's reduction of intrinsic load, we'll compare the relationship between the intrinsic and performance for each group. What we found is that for the box breathing group on the left, intrinsic load is not associated with performance. So residents who reported higher levels of intrinsic load did not receive lower performance scores. However, in comparison on the right, their control counterparts saw a decrease in performance scores associated with higher levels of intrinsic load, demonstrating the protective effects of box breathing from cognitive overload and performance decline. Considering all participants in the OSCE, so now independent of the intervention arm, we found that higher levels of stress was associated with higher levels of cognitive load. And those who reported higher levels of cognitive load received lower resuscitation performance scores. Similarly, those who were more stressed also got lower performance resuscitation scores. But how exactly is stress contributing to cognitive load? What we found was that stress was significantly associated with both intrinsic and extraneous cognitive load. However, this relationship was actually 15 times stronger for intrinsic than extraneous. So to wrap it up, what we found is that box breathing had a significant effect on lowering intrinsic cognitive load in a manner that actually protects residents from cognitive overload and subsequent performance decline. These findings support the integration of box breathing into residents' resuscitation training. In keeping with the literature and our pilot study results, for all residents, high stress and high cognitive load were correlated, and both led to a decline in resuscitation performance. Furthermore, we found that in the simulated resuscitation environment, stress contributes to both intrinsic and extraneous load, however 15 times more to intrinsic load. This supports the claims of many clinical cognitive load experts who believe that stress is inherent to the difficulty and emotion of resuscitations and primarily contributes to intrinsic cognitive load, and our simulation captured the clinical aspects of that. In conclusion, we have demonstrated that box breathing can in fact decrease the task-specific intrinsic cognitive load of junior residents associated with stressful resuscitations in a manner which actually has positive implications on their simulated resuscitation performance. Future work will explore the clinical and pedagogical applications of box breathing in residency training. Thank you for your time and attention. I hope that the next time you're under stress, you take a moment to take a breath. Thank you to my co-author and roommate, Gilmar Gutierrez, and my mentors, Drs. Chaplin and Dr. Selesky. I'll now take this opportunity to take any questions. Thank you very much for your time.
Hi, my name is David Helfer. I'm a medical student at the Perelman School of Medicine at the University of Pennsylvania. I'd like to begin by thanking the SAEM committee for the opportunity to present our research, looking at clinical factors associated with significant coronary lesions following out-of-hospital cardiac arrest. I don't have any disclosures at this time, and I'd like to acknowledge the support of the Emergency Medical Foundation and the SAEM Foundation for their support of this research. Out-of-hospital cardiac arrest afflicts over 350,000 people in the United States each year, with a survival to discharge of less than 20%. Of those patients, significant coronary artery disease has been identified in over 70%. Coronary angiography with subsequent percutaneous coronary intervention has been associated with improved morbidity and mortality. However, broad clinical uncertainty remains in patient selection for post-arrest coronary angiography, especially in the absence of ST segment elevations on the post-arrest EKG. We hypothesized that early clinical factors may be associated with significant coronary lesions after out-of-hospital cardiac arrest. Examples of potentially relevant clinical factors included past medical history of myocardial infarction or coronary artery disease, as well as symptoms prior to arrest of acute coronary syndrome. In addition, we hypothesized that EKG findings, including ST segment and T-wave changes, would be relevant. If true, these clinical factors could be useful in the future to guide clinical decision-making in the emergency department. To do this, we conducted a multi-center cohort study of adult patients resuscitated from atraumatic out-of-hospital cardiac arrest who went on to receive coronary angiography and their subsequent hospital admission at 7 academic hospitals between 2015 and 2019. We abstracted data from EMS run sheets in addition to the emergency department and hospital medical records. This is a list of the study sites included in the study, and a special thanks to Temple Health, Reading Hospital, and Christiana Care for participating. Our primary outcome was the presence of clinically significant coronary disease. And in this setting, clinically significant was defined as greater than or equal to 50% stenosis of the left main coronary artery, or greater than 75% stenosis in the other coronary arteries, as consistent with recent cardiology literature. Secondary outcomes included whether or not percutaneous coronary intervention was performed, as well as survival to discharge and neurologic impairment. we identified 331 out-of-hospital cardiac arrest patients in our cohort. They had a median age of 60, were about 1/3 female, 1/3 Black, and had a median BMI of 30. Of those who had significant coronary lesions present on coronary angiography, they were more likely to be older, less likely to be female, and less likely to be Black. Those with significant lesions were more likely to report chest discomfort and more likely to have an initial shockable rhythm. Looking at past medical history, we found that those with significant lesions were more likely to have a past medical history of coronary artery disease, high cholesterol, prior myocardial infarction, or a prior cardiac arrest. In regards to EKG findings, we found that those with significant lesions were more likely to have ST segment elevations or depressions, as well as an initial troponin that was positive or greater than 0.04. In terms of our secondary outcomes, percutaneous coronary intervention was performed in just under half of our patients. We had a mortality rate of 46%, which interestingly was consistent amongst those with significant lesions and those without significant lesions. Median ICU stay of 4 days. Over half of our patients had significant coronary lesions, and there's a breakdown of the multivessel disease in the left-hand corner. In this plot, you can see the 6 clinical factors that had the highest adjusted odds ratio with having greater than 1 significant lesion. I'd like to draw your attention to the top 3, which included a history of myocardial infarction with an odds ratio of 11, chest discomfort with an odds ratio of 7, and having ST segment elevations on the post-rest EKG had an odds ratio of 3 for predicting greater than 1 significant lesion. Also statistically significant were odds ratios of ST depressions, male gender, and initial shockable rhythm. A few limitations of this study include selection bias. Being a retrospective study looking only at those who received coronary angiography, we have no data to report on those patients who did not receive coronary angiography, and as such, are beholden to some of the selection by the providers in choosing patients to receive coronary angiography. In addition, symptoms of acute coronary syndrome may have been undocumented in the EMS run sheets. That does not necessarily signify that those symptoms did not occur. However, it was out of our knowledge and out of our reach for this study. In conclusion, report of chest discomfort prior to arrest, previous history of MI, ST segment elevations or depressions on post-arrest EKG, and an initial shockable rhythm were all independently associated with the presence of significant coronary disease. We think that these clinical factors have potential to be used in developing a scoring system for guiding the use of coronary angiography as part of out-of-hospital cardiac arrest care. I'd like to thank the Penn research team at the Center for Resuscitation Science, as well as our collaborators, and I'm happy to take any questions at the end of the session. Thanks so much.
Hello, my name is Demetrius Neophtidis. I'm a 4th-year emergency medicine resident at Lincoln Medical Center in the Bronx. This is a lightning oral abstract presentation. Our abstract is titled Cerebral Oximetry, an additional resuscitation marker to lactate and mean arterial pressure. Authors of this abstract are Dr. Daniel Singer, Dr. Nicholas Caputo, and myself. We have no financial disclosures or conflicts of interest. For a little background, current literature on cerebral oximetry is dominated by its use in the operating room and during cardiac arrest. Noted in the cartoon are the near-infrared spectroscopy sensors, or NIRS, which emit infrared light at a wavelength of 700 to 950 nanometers. This is not absorbed significantly by the skin and enables non-invasive monitoring of the regional hemoglobin oxygen saturation in the brain, or RSO2. NIRS electrodes are placed on the scalp above the frontal cortex, an area of the brain which is most prone to hypoxemia, as it is a watershed area supplied by the anterior and middle cerebral arteries. NIRS samples 70% venous blood. It does not rely on arterial pulsation as traditional finger SpO2 monitoring, which is one reason why it is a beneficial tool in cardiac arrest patients. Due to this fact, normal RSO2 levels are between 60 and 80%. Since RSO2 reflects the overall cerebral tissue oxygen supply demand, Supply diminishes due to fall in oxygen delivery, or DO2, then the RSO2 will fall. Similarly, it will fall if there's an increase in oxygen demand not matched by an increase in supply. As we know from the equation for delivery of O2, in the absence of severe anemia, we can best augment global DO2 by changing cardiac output via preload or ionotropy. What this equation fails to address is the dysregulation of cerebral autoregulation that occurs in sepsis and other shock states. MAP can be a poor indication for regional oxygenation during these states and has been suggested as a possible mechanism for postoperative cognitive decline. Alternatively, techniques for monitoring global rather than local or regional brain oxygenation, as with RSO2, are considered too invasive for routine use, such as intravascular catheters to assess jugular venous oxygen saturation. What a review has showed us and what we expect to discover is cerebral oximetry is specific for tissue oxygenation does not equate with MAP and lactate in this regard. Our aims of this study to determine how lactate and MAP compare to cerebral oximetry as a marker of tissue oxygenation in patients. Lactate and MAP have been shown to be at times poor indicators for meeting resuscitation goals, and as emergency medicine has moved away from bundles and towards patient-centered resuscitation, cerebral oximetry may offer a personalized approach to cerebral oxygenation and a new goal for resuscitation endpoints. Given this documented failure of MAP and lactate goals in certain shock states, we also sought to determine whether patients who had met classical definitions of appropriate resuscitation or compensation also suffered from cerebral hypoxia. For our methods, the design of the study was a prospective observational study. Population was those over 18 in the ED with a central line placed. Data collection measured, CO was measured using the INVOS cerebral oximetry system as pictured below, the same time of blood gas collection and MAP measurement. Statistical analysis was generated using the Bland-Altman plot for level of agreement and bias, and Pearson correlation was calculated to describe relationship between CO, MAP, and lactate. Results of this study showed at the interim analysis that 38 patients were included in this study, 29 of them on vasopressors. 21 of the 38 patients had cerebral hypoxia. Interestingly, of the 21 patients with cerebral hypoxia, 14 of them had a lactate less than 4, and 16 of them had a MAP greater than 65. As noted in the Bland-Altman plot, there is a poor level of agreement between both MAP and CO, and if we look at the scatter plot for correlation of CO and MAP, we get a Pearson correlation coefficient of 0.1 and an R squared of 0.009, indicating a positive correlation between CO and MAP. When looking at the results of the study group for lactate and CO, we say they too have a poor level of agreement on the Bland-Altman plot. And looking at the scatter plot for correlation of the lactate and CO, we see a Pearson correlation coefficient of negative 0.05 and an R squared of 0.025. Conclusions of this study show that there is utility for CO as a diagnostic and resuscitation endpoint and confirm that lactate and MAP are not specific markers of tissue hypoxia. A goal of MAP greater than 65 and or lactate less than 4 does not rule out cerebral hypoxia. Furthermore, the majority of patients with cerebral hypoxia had a MAP greater than 65 and or a lactate less than 4. However, MAP does have a strong correlation with CO. A higher MAP is associated with a higher CO. Future studies may determine causality of a higher MAP leading to an increase in CO. Limitations of this study. Again, this is an interim analysis with recruitment still ongoing. This was a heterogeneous and small population from a single center, mostly of critically ill patients, and we may find different conclusions for moderately ill patients. These are my references. Thank you for your time.
Thank you for this opportunity to present our research here at SAEM. Our research is entitled The Utility of Interval Likelihood Ratios of Lactate to Predict Mortality in COVID-19 Patients. Neither myself nor any of my co-authors have any financial conflicts of interest to disclose. So we'll start off talking about the role of lactate. Now, obviously, many of us providers recognize lactate is often designated as a marker of end-organ perfusion. And that's clearly an oversimplification of its role in biochemical processes and various different disease states. But nonetheless, it does serve a role as a predictor of mortality across many different diseases. And it is associated with an increased mortality and nowhere else, and we can see this elucidated in the sepsis literature, where its role obviously serves as a marker of in-hospital mortality, but also as a marker of disease severity and determination in the guidance of resuscitation management of these patients. So obviously determining what each different value really means has incredible importance. And so, for example, a lactate value of 3, while may confer an increased mortality risk, certainly should not be equated to the same of a lactate value of, say, 8 or 9. Now, when we take a look at patients with COVID-19, we do see that there is an increased association with mortality and elevated lactate values, but what each individual value really means has not yet been elucidated. So in order to look at that, we designed our study to determine if the interval likelihood ratios of lactate when drawn in the emergency department can provide a better clinical significance for predictor of in-hospital mortality of patients with COVID-19. So our study was designed as a retrospective single-center study in which we performed a chart review for all patients admitted to the hospital between March and April in 2020. Now, it is important to note that at this time, it was the peak surge for COVID-19 in New York City in that spring, as well as a time in which the hospital was designated as a COVID-19 only hospital. All our patients who were included were those who had an initial lactate drawn in the emergency department, whose visit mortality could then be calculated. We subsequently performed receiver operator characteristics analysis on this, as well as the interval likelihood ratio analysis we mentioned previously, and took a look at the post-test probability for invasion analysis in that sense, and compared it to the performance of the test of the receiver operator characteristics. We also subsequently performed a Kaplan-Meier analysis in which we took a look at what the median time to death was for patients with elevated lactates. So we had 445 patient encounters with a cohort mortality rate of 43%, obviously pretty elevated as elucidated by the time period that I mentioned. And of course, we did note that initial lactate was associated with increased mortality. When we go into the receiver operator characteristic analysis, lactate was significantly associated with an increased mortality with an area under the curve of 0.68 and an optimal cutoff as determined by this of 2.35, or slightly above the upper limit of normal. Now, of course, we know that a lactate value of 3 certainly does not provide the same level of prognostication as a lactate value of, let's say, 8 or 10. Now, of course, they do both correlate with an increased mortality, but how do we determine exactly what each of those levels mean? And to do that, we performed interval likelihood ratio analysis, and then subsequently took a look at how that affected the post-test probability of patients with various different lactate levels. So as I mentioned before, for our pre-test mortality rate of the entire overall cohort mortality of 43%, and it wasn't really until we took a look at lactate values that were greater than 4 did we really see a clinically significant increase in the mortality to 72%. Now, of course, patients who had a lactate value between 2 and 4 did have an increased rate of mortality, but nowhere near what we'd see with those elevated lactates. And patients who had lactate levels less than 2 also had a lower likelihood of mortality. For those who prefer a graphic representation, on the right is a Fagan nomogram showing the different lactate values. And when we get above 4, we really start to see that the likelihood ratio shows a quite clinically significant jump in the post-test probability for mortality in these patients. When we take a look at the Kaplan-Meier analysis, patients who had a normal lactate had an average median time to death of about 15 days and decreased a little bit once you got above a lactate of 2, but nowhere near where we started seeing the significantly shorter time period of median time to death until you got a lactate greater than 4, in which your median time to death was about 4 to 5 days. So obviously our study had some limitations. One, the biases associated with the study design I talked about. And of course, we do have to know that this was a time in which hospitals were overwhelmed with unprecedented levels of hospitalization. It was certainly before we had the recovery trial or various different studies elucidating therapeutics for COVID-19 at this time. And so that needs to likely represent the higher cohort mortality rate for our patients. We, of course, don't have any information on data or symptom onset. And we looked at the entire hospital mortality, which could have included patients who died from other causes. So in conclusion, a lactate greater than 4 is significantly associated with in-hospital mortality for patients presenting with COVID-19, and it's a shorter median time to expiration. And this type of analysis provides a little bit better clinical significance than just typical receiver-operator characteristics, providing a dichotomous cutoff. And with that, these are my references, and we'll leave it up to any questions.
Hello, everyone. My name is Jeffrey Marco. I'm a second-year resident at the University of Pittsburgh Medical Center. My talk is entitled "The Timing of Epinephrine Administration for Patients, Pediatric Patients with Out-of-Hospital Cardiac Arrest." I have no financial disclosures or interest to disclose. So a little bit about the background. Unfortunately, there are greater than 20,000 infants and children who suffer from out-of-hospital cardiac arrest yearly. Epinephrine is part of our algorithm for resuscitating these patients. However, the optimal timing of epinephrine administration is a big knowledge gap, and evidence of these recommendations are severely or limited overall. One of the important and unique biases to addressing these studies is the concept of resuscitation time bias, which essentially states that the longer an arrest occurs, the more likely you are to or providers to intervene in terms of airway management, intubation, things of that nature. However, these long arrests are also associated with worse outcomes. So the bias that would come into play would be that intervening with these procedures and things of that nature would be associated with worse outcomes. However, we know that's not necessarily the case and doesn't tell the full story. So our main objective was to evaluate the association between the timing of epinephrine administration and patient outcomes after pediatric out-of-hospital cardiac arrests. Our main study design or study setting was based in 10 different sites throughout North America, in the United States and in Canada, and we used a database that identified patients who had suffered out-of-hospital cardiac arrests. Our study participants included pediatric patients under the age of 18 who had suffered EMS who had suffered out-of-hospital cardiac arrest and were resuscitated by EMS personnel. And some of our exclusion criteria shown here. For the most part, it's missing data or being administered medications that were not epinephrine, such as vasopressin and things of that nature. So our main exposure was the time interval between the arrival of these EMS personnel and the administration of the first dose of IV or IO epinephrine. Some of our outcomes that we were looking at was the survivability and the favorable functional outcomes at hospital discharge. So unfortunately, when you are performing these observational studies, you do not have the benefit of randomization as you would in a randomized control study. So in order to account for that, we used time-dependent propensity score and risk set matching analysis. And I'll illustrate this in the next slide, but all it is that the time-dependent propensity score is a probability of receiving epinephrine at a specific time interval. And what we did was we matched that time interval of one patient to a similar time-dependent propensity score of another patient who had received epinephrine. So I can show that to you on the next slide here. You can see patients A through E on the left, time intervals 1 through 4 on the bottom, and each patient is assigned a propensity score. For patient A, it's 0.30 at time interval 1 and 0.72 at time interval 2. As you can see, these propensity scores were then matched. So for patient B and C, you can see they both had propensity scores of 0.53, and they were matched. Patient B received epinephrine, and patient C did not. So that's how we were able to get our matching values of our patients who did and did not receive epinephrine and undergo our study analysis. So figure 1 here just demonstrates how we derived our analyzed cohort after some of our exclusion criteria. Table 1 here demonstrates the key characteristics of the patients who had received and had not received epinephrine. So you can see 267 did not receive epinephrine, 765 did receive epinephrine, and the median time interval for those who did receive epinephrine was approximately 9 minutes. Table 2, very similar to Table 1, demonstrated the characteristics of the patients after time-dependent propensity score and risk set matching analysis. So here you can see that 738 patients were in both categories. However, for the time interval, time interval for epinephrine administration was 4 minutes shorter for those who did receive epinephrine, 8 minutes versus 12 minutes for those who did not receive epinephrine. So here's our outcomes to hospital discharge using, with respect to time, using time as a categorical value variable in increments of 5 minutes. So 0 to 5 minutes, 5 to 10, 10 to 15, so on and so forth. We use risk ratios, and you can see that the risk ratio is the highest in the 0 to 5 time minute interval. However, based off the confidence interval, we can conclude that this was not determined to be statistically significant. Very similar to before, however, looking at favorable functional outcomes using time as categorical values, again, risk ratio was the highest in the earlier you gave epinephrine. However, based off the confidence interval, was not statistically significant. So some of our limitations included unmeasured confounders, reporting association and not necessarily causation, and having a specific group and not having the external validity that you would like because we were using a specific cohort of patients. So our conclusion was that in EMS resuscitated pediatric out-of-hospital cardiac arrest, the timing of the first epinephrine administration was not associated with an increase in survivability or favorable functional outcomes at hospital discharge. Thank you so much for listening tonight.